Dr. Bhargavi will start the session.
Yes, yes, we'll start.
Nitin, summarize your case, please.
So, a 50-year-old female patient, Loabai Shinde, resident of Shirur, Latur, laborer by occupation, Hindu by religion, and belonging to the lower socioeconomic status, came to the OPD with the chief complaints of a lump in the right breast since 1 year and associated with the pain since last 15 days. So, shall I read all the
No, no, summarize your till there.
Okay. The patient was apparently all right when she noticed a lump of size of a pea in her right breast in upper outer lateral quadrant and 1 year ago, which was insidious in onset and gradually progressed to the current size of a ball. There was lump is associated with pain since last 15 days. There was a history of recent weight loss, but no history of rapid increase in size, similar swelling, discharge from nipple,
No,
redness.
no. When the examiner asks you to summarize the history, you need not tell all the history. You just tell the positive findings. If at all the patient has any positive findings, only the positive findings.
Okay, ma'am. So the lump was associated with the pain since last 15 days. There was history of recent weight loss and uh, patient showed with a loss of appetite and
There is the family history is not contributed. The menstrual history is not significant. Basta.
not significant. Yes.
Then the examiner asks you based upon the history till now, what is your provisional diagnosis? What is your diagnosis? What all the things that are coming into your mind before going to examination?
Okay, ma'am.
What is your diagnosis until now based on
Uh,
your history?
until now, the diagnosis is carcinoma breast
Why?
uh, due to recent history of weight loss and uh, loss of
No.
appetite.
Go to your first slide. Go to your first slide.
Uh,
So seeing everything. Why carcinoma breast? First the age group,
age group.
elderly age group,
Yes, ma'am.
and she have given only history of 1 year. There is no swelling before. Only in 1 year it has progressed,
Yes, ma'am.
and there is a history of weight loss. There is a
Yes,
history of loss of appetite. Go
yes,
to the
ma'am.
next slide. So based on all these things, and it is insidious in onset, sudden, almost gradual progression over only 1 year. So
Yes.
based on this, it is malignancy. What more can it be? Other than malignancy, what more? What is your second thing? Other than malignancy in this patient, based upon the history, what is the one more differential diagnosis based on history?
Mm,
Elderly age group, throbbing type of pain, and
breast
small.
abscess can be
Breast abscess in this age group, unlikely. What is the similar type of thing in old age, like breast abscess? Yesterday
mm,
also I have talked about that.
okay, ma'am.
Periductal mastitis.
Okay,
But in this quadrant in which you are telling upper outer quadrant, it is unlikely. Okay. So mostly
okay.
your primary thing is carcinoma breast.
Maximum opus. Okay.
Let's go to the general examination.
So the patient was examined in a well-lit room with prior consent. She was conscious, cooperative, well-oriented to the time, place, and person. The respiratory rate was 16 per minute with normal chest movements. Pulse rate was 80 beats per minute, measured in a left radial artery in a sitting position, having normal rhythm and volume. Blood pressure was 130 by 90 mm of Hg, measured in a left brachial artery in sitting position. The weight of the patient was 58 kg, height was 155 centimeter, and BMI of 24. Uh, there was no sign of pallor, icterus, cyanosis, edema, or clubbing.
Okay.
Ischemic examination,
No, the
CNS,
systemic examination should be told in the end, not now. You can tell head to toe examination, but systemic examination should be at the end.
Okay, ma'am.
You can tell if it is a female, there is no thyroid swelling, the spine examination appears normal, there is no deformity of the spine. All those you can tell.
Okay, ma'am.
Yeah.
So there is no thyroid swelling and no features of hypo or hyperthyroidism, and spine is normal, no tenderness or deformity is seen.
Okay.
Then local examination. So, in inspection, patient was examined in a well-lit room with arms on side, arms on hands raised above, hands on hip, and bending forward position, and breasts were exposed till waist.
With due consent of the patient in the presence of female examiner.
Sorry, ma'am, you are not audible.
Uh, with due consent of the patient in the presence of a female examiner.
Yes, ma'am.
Yeah.
Should I mention that here, ma'am?
Huh?
Should I mention that
Oh.
in
Yeah,
female?
yeah, 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 yeah. First, yeah. Sir, I want to proceed with examination. With I have taken the consent of the patient, and the patient is being accompanied by the female examiner. Can I continue? That's what you have to ask.
Okay, ma'am.
Yeah. If the female attendant is not there, you can ask one of your senior. Any resident will be there during your exam. You can ask the resident to come, the female resident to come and stand by your side.
Okay, ma'am.
Yeah.
Okay. So, on sitting position, the left breast appear to be normal in position, side shape, with normal nipple area or complex, with no changes over skin. There are no swellings present over breast and also no swellings present over axilla, arm, and thorax.
Okay.
In right breast is slightly displaced toward outer direction and is slightly bigger in size than the left normal breast. Nipple is at slightly lower level than normal breast. Other than nipple area or complex appears to be normal. No cracks, fissure, and discharge is seen.
Do you
Skin,
have photo of this patient?
no, ma'am.
Okay. Okay. Continue.
The skin over breast shows engulfed veins without any redness and edema. A small puncture wound of recent Rupert biopsy is seen over upper lateral quadrant of the right breast. Uh, no dimpling or puckering, no beauty orange, and no other swelling noticed in axilla, arm, and thorax in right breast.
Next slide.
On bending forwards, both breasts fall forwards, so there is no chest involvement. And on raising arm, the swelling in the right breast becomes more prominent, uh, and no visible swelling is in axilla.
Let's go to the previous slide once. So in the nipple, what are the things you will see?
Uh, is there any retraction or any discharge
Okay.
or any cracks or fissure?
Any ulceration?
Ulceration, yes.
What more? The position of the nipple,
Uh,
whether
yes,
the
ma'am.
position of the whether nipple is at the center or deviated towards one side, which you have mentioned. When
Uh,
there will be the deviation of nipple?
In carcinoma of breast, the deviation of nipples occur towards the direction of the lump. So,
Why?
uh,
Why deviation of nipple towards the direction of the lump?
mm,
Anyone in the group? Why deviation of nipple towards direction of lump?
mm, sorry, sorry.
1 minute. 1 minute.
So because no, basically there will be fibrosis. So in fibrosis, because of malignancy, so nipple will be displaced towards the same side.
Okay, sir.
Okay. And which kind of retraction you will see in the malignancy? There are types of nipple retraction, no? Which kind of nipple retraction you will be seeing in the malignancy, and which kind of nipple retraction you will be seeing in the like ductal ectasia.
Uh, in ductectasia, there will be fish mouth nipple retraction is seen,
Okay. In
or
malignancy,
slit like retraction. Malignancy. uh,
so in malignancy, you will be having circumferential nipple retraction.
okay, sir.
So in duct ectasia, you will be having slit like or as you have to know fish mouth like retraction will be there. In malignancy, you will be
Yes.
having circumferential nipple retraction. And one more
Okay,
thing,
sir.
how will you differentiate between whether nipple retraction is congenital or nipple retraction is malignant due to because of malignancy? How will you differentiate it?
Mm,
There is an entity called as congenital nipple retraction, which is common in 4% of females. So, how do you differentiate this congenital nipple retraction with that of nipple retraction of malignancy?
mm. Uh, in malignancy, there will be unilateral nipple retraction, but if it's congenital, then it will be bilateral.
Okay. What more?
Uh, no idea, sir.
So if there is any congenital nipple retraction is there, no?
Okay, sir.
So if you press at the nipple area complex, that nipple area complex, it will come back to the normal position. Okay. Again, after a few times, no, it will go back. But malignancy, it won't happen.
Okay, sir.
In congenital, if you press at the base of the nipple area complex will become normal. But in malignancy, it won't become normal like this.
Okay, sir.
So basically, you are starting with the exam on sitting position, no? So what are the different position you will do for breast examination, and which one is the best position to examine the breast?
Uh, So semi-recumbent or recumbent position is also practiced in examination, but sitting position is best form of examination
No, no.
because it gives.
Basically, semi-recumbent position is the best position, not your sitting position,
45 degrees.
because breast is your pendulous tissue is there, no? You have to palpate against your chest wall. Any tumor is there, any lump is there. You want to appreciate better with against the chest wall. So semi-recumbent position at 45 degrees is the best position, not your sitting position or your supine position.
Okay, sir.
And which method you are using for a breast examination?
So for palpation
Yes,
For
for
palpation.
palpation.
of dial clock method.
Okay, so dial clock method with like how will the palpate the breast? With the palm you will palpate, or your pulp of the finger you will palpate. How will you palpate the breast?
Uh, we will palpate breast with the pulp of finger in
Pulp of
radial direction from pulp of fingers, pulp
pulp
of
of three fingers. You have to
three
palpate the
fingers,
breast.
and
Three fingers.
yes, sir, and in radial direction in clockwise manner
Radial direction
from
clockwise.
center. Yes.
Okay. Go to your first slide. First slide on examination.
So is this
Hand
or
and yeah, edit hands on hip
Uh,
and
the,
fingers on.
the general examination.
okay, sir.
And what about lymph nodes?
So it will be uh, covered in palpation.
So you have to tell, sir, there is no evidence of generalized lymphadenopathy in this patient. Local examination of
Yes.
lymph nodes I will do in the local examination.
Okay,
First.
sir.
Okay.
Okay, sir.
So you have to tell, sir, there is no evidence of generalized lymphadenopathy, but local examination of lymph nodes I will be dealing with the local examination.
Okay, sir.
Okay. So go to your next part. So whichever patients are there, no, female patient, spine and thyroid examination you have to mention, and head to toe examination also you have to mention in this one.
Okay, sir.
So next one is your systemic examination. Next go to systemic local examination. ठीक है, next.
So
Nipple is slightly lower than normal breast. Okay, fine. Start. Skin over the breast.
shows engulfed veins without any redness or edema.
So what does it suggest? Saying skin over breast shows engorged veins.
Uh, it suggests rapidly growing. Sorry, sir.
So it is a
It's
kind of
rapidly
vascular, or it is a rapidly progressing growth.
rapidly progressive. Yes.
So yesterday we have discussed no one time Monroe's disease, that is superficial thrombophlebitis of the veins also.
Yes.
Okay. What do you meaning by dimpling? Why dimpling will happen?
Due to involvement of Cooper's ligament, there is a stretching of the ligament due to fibrosis, and dimpling occurs on the surface of the
What is
breast.
Cooper's ligament?
From where does the Cooper's ligament come?
What is the function of Cooper's ligament?
Anyone can answer. If at all anyone knows, please do answer. What is the suspensory ligament of the breast? Cooper's ligament is a suspensory ligament of the breast, so it suspends the breast from the anterior abdominal wall.
Yes, ma'am.
So
What
basically
is the
your
difference between
Cooper's ligament is are these are the suspensory ligament arising from your prepectoral fascia to it will go and insert to your breast tissue, so that it will give shape to your breast tissue, and
Yes.
proper anchoring will be there with the chest wall. From chest wall it will arise and it will go insert into the breast tissue. So if there is any involvement of Cooper's ligament is there, so you will be seeing dimpling. And where you will see the puckering? What is the difference between
If
dimpling and
there,
puckering?
if there is involvement of multiple Cooper ligaments, there multiple dimplings
So if there
are
is
seen.
involvement of single Cooper ligament, you will get dimpling. If there are multiple involvement of Cooper ligament, you will get the puckering.
Occurring.
So dips.
what is tethering?
Sorry, ma'am.
What is tethering? Tethering.
No idea.
You have told about dimpling. Now, what is tethering then? Tethering is the palpatory manifestation of dimpling. Whatever you see, you have puckering. Na? On palpation, whatever you do after doing, matlab, if you are palpating the mass and you move it to the extreme position, the dimpling will become more prominent. Na?
Yeah.
That is
Yes,
called
ma'am.
tethering. It's the palpatory finding of the dimpling. What you call it is tethering.
Okay, ma'am.
Uh, what do you see actually by okay, let's go to the okay, fine. Skin over the breast is engorged.
So what is your
Dimpling.
purity orange is due to?
Purely orange.
Uh, Purity orange is due to inflammation of the skin over the breast, uh, and
So why does purity orange appearance will happen? What is the pathophysiology behind that?
due to blockage of superficial lymphatics of the skin over the breast, there is a swelling, and the hair follicles will be stretched due to edema, and orange peel skin like appearance is seen
See,
over the breast.
Nitin, no, there is only one single word is there due to involvement of subdermal lymphatics.
Sorry, sir.
Due to
Due to
involvement of your
involvement of
subdermal
this
lymphatics.
Okay, sir. Subdermal.
subdermal lymphatics.
Okay.
Okay. So does your dimpling or puckering will come under skin manifestation?
Mhm. No, sir. So dimpling and puckering is not a skin manifestation.
So which one is your skin manifestation?
Uh, so pure orange and
Ulceration
Yesterday
and your
I have asked you this question.
the pure orange is skin involvement,
hmm,
and
purity orange, ulceration and your satellite
yes,
nodules.
yes. Satellite nodes. Yes.
Okay. So these are the only your skin manifestation.
Ulceration, Veda, ulceration, not ulceration, fungation, and purity orange along with satellite nodules.
Yes.
Okay. No other
Okay.
swelling noticed in axilla. Which swelling you want to see in the axilla?
Any lymph node, axillary lymph node, uh, enlargement or any
Cancer
accessory
increase,
uh,
accessory breast.
accessory breast or cancer increase.
And you want to look at the opposite axilla also. You mentioned
Mm,
left breast no swelling present or axilla. So basically, you want to roll it any metastatic to the opposite side.
okay, sir.
So what was that classification? Yesterday we asked, no, that is your Mishra's classification. Or Mishra
Okay, sir.
criteria is there, where you will be seeing whether it is arising from the same breast tissue or whether it is a primary or secondary. That is your Mishra's classification. Okay,
Okay,
read
sir.
about Mishra's classification. Go to next
Okay.
slide. On bending forward, both the breasts fall forward. On rising arm, swelling right breast become prominent. No visible swelling in the axilla. And also on rising arm, what which site you want to see specifically?
Uh, Axilla and lateral side of arm.
Basically, you want to see the inframammary crease or inframammary fold.
Okay, sir.
Okay, so basically, you want to see the inframammary fold, and also if there is any swelling,
इसमें
it will go.
bilateral breast cancer is it's Mishra's or it's Chowdhury and Miller?
Sorry, it is Chaudhary Miller classification.
Yes, yes.
Okay, sir.
It's Chowdhury and Miller classification, bilateral breast cancer.
Okay, sir.
Yeah. Continue.
Go to the next slide.
Yes.
Uh,
Uh,
Nitin, I want to ask you, why do you ask the patient to lean forward? What do you want to check?
if there is association or if there is tumor is attached to the chest wall or muscle,
Okay. Why did you ask the patient to press against the waist?
uh, to check if the tumor is attached to the pectoralis muscle or not. We ask patient to tout
So
the
basically,
pectoralis.
not your pectoral muscle. You are going to test with your chest wall involvement.
Chest wall involvement. And what more thing you will see while asking the patient to press against the waist? Whatever you are telling that you're dimpling, you're puckering, it becomes much more prominent when the patient does it.
Yes, ma'am.
Okay. Why do you ask the patient to raise arms above the head?
Uh, to see uh, the folds in
Yeah.
the folds of
Inframammary fold, and
intramammary fold.
also yeah, and also your same your dimpling becomes much more prominent
Much
when the
more
patient
prominent.
rises.
Yes, ma'am.
Okay. Let's go to next slide. Continue.
Palpation. The patient is examined in sitting position. Left breast, there is no
So
local rise of
basically,
temperature.
you have to tell the patient is examined the semi-recommended position. You only told us that is best position, so not your sitting
Okay.
position.
Okay. So,
Next,
left breast, there is no local rise of temperature and tenderness. In right breast, there was no local rise in temperature and no tenderness. There is a single lump in upper lateral quadrant of size approximately 10 by 8 centimeter, extending from mid-axillary line to the mid-clavicular line horizontally and 7 to 8 centimeter above the nipple and 2 centimeter below the nipple vertically. It is hard in consistency with uneven surface and regular well-defined margins. Lump is not fixed to the skin, underlying breast tissue, pectoralis major, or chest wall. There is no blood or discharge on compressing. And I would like to do PV and beaver examination for pelvic deposits.
see, your left breast is normal. Always you want to do examination of normal side. So there was no local temperature, no tenderness, lump in the upper lateral quadrant of size 10 to 8 centimeter. Upper only it is involving only upper and upper like upper outer or upper inner. Only upper
Per
quadrant is
outer.
involved.
Yes, sir.
But the based on the diagram which you have drawn, I think it is involving lower quadrant also, and
Involved.
also it's going to the inner quadrant also. Yeah, that's right. The diagram which you have shown, it's going to the lower quadrant and it's going to inner quadrant also, right?
Uh,
So you
Sorry.
have to mention if at all it is going to any other quadrant, my lump is this much. It is also these quadrants are also getting involved.
Okay,
So the
ma'am.
patient, because the examiner will not see the patient immediately, right? So he can visualize, okay, okay, this much big lump, it's going into all quadrant. Why is it important? Why? Okay, imagine we are having during COVID time, all this having this virtual meetings and those. The examiner is not seeing the patient. So why your diagram and your all these so-called palpatory findings are important? Why this case presentation came? All these things is why it is important. So imagine if it is such a big lump involving every single quadrant. Almost, I think only the inner lower quadrant is paired based upon your diagram. Almost it is involving almost at least slight bit of every single quadrant. Where do you take an incision? Almost it is involving entire breast, right? You
Yes.
won't get any skin flap to close because you will be taking all the skin which is over the breast lump.
Yes, ma'am.
So how do you plan surgery? You have to close, right? You have to close the skin flaps. Imagine whole of the skin you are removing over the breast. So you can't do anything, no?
Yes, ma'am.
So that's why the proper history and what all you are mentioning is important.
Okay, ma'am.
Yeah.
So you are telling the lump is uh, lump is there is underlying tissue pectoral and chest wall. How you are examining the lump is fixed to the pectoralis major or chest wall.
We asked the patient to put hands on the waist and out the pectoralis muscle, and then we
Okay,
move the
first
lump
no.
in the
No,
direction.
no, 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 no.
Sorry, ma'am.
No, no, no. How do you start? How do you start examining whether the patient is having pectoral fixity? First, you do in relaxed position, right?
Sorry, ma'am. Yes, ma'am.
First, you will see in relaxed position. You will move along the direction of fibers.
Yes, ma'am. Yes.
Yeah,
Sorry.
continue. Start telling. How do you
Uh,
check pectoral fixity?
then we have first move the lump in the direction of the fibers, and then we ask the patient to place hands on the waist and out the pectoralis muscle,
How
and
do you
then
check the taut, whether the pectoralis muscle is taut or not?
uh,
Check the anterior axillary fold, whether
anterior,
it's constricted or not.
yes, ma'am. Anterior border of the pectoralis muscle, and then uh, we try to move the tumor in the direction of the fibers of the pectoralis major. If it's not moving along the fibers, then it's fixed. Uh, it's moving freely, then it's not fixed to the pectoralis muscle.
What?
If it's moving along the fibers, then it's not fixed to the pectoralis muscle.
You know any moving against the direction of fibers? Along the direction of fibers, what is important? So your pectoralis fibers are like this, and you have a lump like this. You are moving in this direction, and you are moving in this direction. What is the importance? So these are how pectoralis fibers are. So this is your lump. This is the along the direction of fibers. See, these are the fibers. This is along the direction of fibers. This is opposite to the direction of fibers. What is importance?
Mhm. Sorry.
So basically, first initially you have to see whether lump is freely moving or not. Okay. So first check the mobility of the lump. If lump is initially not moving, it suggests of it is fixed. So there is no need of doing any pectoral fixation or making pectoralis major muscle taut and all. So if you first move the lump and see whether lump is moving freely or not. If the lump is fixed, no, so there is no need to do any other test.
Okay,
So
sir.
suppose if you are doing if first you have to move the lump in both the direction. You have to move in vertical and horizontal direction. Move the lump in both the directions. See, basically you have to move the lump in both the direction. If the lump is freely mobile, then you have to see whether lump is attached to the pectoralis major muscle and all. So for that, you have to do the pectoralis major muscle taut and up, and you have to ask the patient to keep hands on the waist, to make the pectoralis major muscle contract. and you have to feel the entry axillary fold to make whether pectoralis major muscle made taut or not. After that,
Okay, sir.
okay, after that, move the lump first in the direction of muscle fibers, then move the lump against in the against vertical to the muscle fibers or perpendicular to the muscle fibers. You have to move the lump, and you have to
Okay, sir.
compare the relative mobility. Like initially, you have to move the lump whether it was freely mobile. Now, whether lump is in having little bit restricted mobility. So that is relative mobility is important. Whether lump is freely mobile or relative mobility is restricted. And
Okay, sir.
also after doing pectoralis major muscle contract, you have to see whether lump is becoming more prominent. Suppose if lump is becoming more prominent, lump is arising lump is not attached or it is above the pectoralis major muscle. If lump is becoming less prominent, it is suggestive of lump is going behind the pectoralis major or it is going behind the retromemory area. So you have to see the lump size also along with your mobility.
Okay, sir.
Okay, so that is the importance of your making pectoralis major muscle torque. And one more thing, you should not ask the patient to make pectoralis major muscle contract continuously. You have to ask the patient to make intermittent pectoralis major muscle contraction and relaxation. Because
Okay,
if you
sir.
make the pectoralis major muscle contract continuously, so there will be fatigue and automatically it will get relaxed and it will be showing you false impression of pectoralis major muscle is in contracted state. So ask the patient to do intermittent pectoralis major muscle contraction and relaxation. So that is how you do the whether it is attached to the pectoralis major muscle or not.
Okay, sir.
Okay. So lump is not fixed to skin. Basically, you have to pinch the skin to see whether it is not fixed to the skin or not. And
Okay.
so when moving the lump, how the lump was moving, whether lump was moving independent of the breast tissue or lump is moving with the breast tissue. Did you
Sir,
get my question?
uh, the lump was
Lump was
moving
moving with the breast tissue or
with the
within the
breast
breast
tissue.
tissue.
It was moving with the breast tissue.
So suppose if it was moving within the breast tissue, what it was suggestive of?
If it's moving within the breast tissue, it's suggestive of fibroadenoma
So if
because
it is
it's
moving within the breast tissue, suggestive of more likely benign, and it is a fibroedema that is called as mouse in the breast.
mouse in the breast.
So
Yes,
you
sir.
have to mention specifically because you have missed that point too. So the lump is moving with the breast tissue.
Okay, sir.
You have to add that point. So lump is moving with the breast tissue. So
Okay,
first,
sir.
when you are going to the starting examination, first don't go and jump to the your lump. Start palpation from your nipple area complex.
Okay, sir.
What are the quadrants of the breast?
There are
How many
four
quadrants are there?
quadrants.
How many quadrants are there in the breast?
There are four quadrants.
No, no, no. There are five quadrants. Which one is the fifth quadrant? So your
Sorry,
nipple
sir.
area complex is your fifth quadrant.
Okay, sir.
Okay, so there are five quadrants in the breast. Nipple area complex is your fifth quadrant. So start palpating centrally and go in the radial direction. First palpate the nipple area complex. While palpating nipple area complex, you have to see if there is any subaerial or any lump is there. So if you are feeling any subaerial lump or because most of the time, no, you will feel the lump only. You will be missing the nipple area complex. You have to hold the nipple area complex and you have to palpate the base of the nipple. So while palpating base of the nipple, no, you will be feeling any lump is there, any nodularity is there. Okay. So it suggests you because your Paget disease there, no, Paget disease will be having a lump in the subareolar area. So you have to feel the nipple area complex first, then go to your lump.
Okay, sir.
So this PV and PR examination, no, it will come under your systemic examination, not in this examination. Suddenly you are doing breast examination, going to PV and PR examination is not good. First go to your nipple examination, then go and doing PV and PR examination. So always start
Rather,
first
you
one
would have
nipple
mentioned
complex.
about lymph nodes here. Rather, you would have mentioned lymph nodes here, na, in palpation.
No, ma'am, I've mentioned it
Okay,
separately in lymph node.
it's okay, fine. So PV and PR examination, no, add in your systemic examination, not in this. Go to the next slide.
Okay, sir.
Next slide.
Just 1 minute. One
Okay.
minute, sir. So here I have mentioned the examination of lymph nodes.
So no, so see, basically, first again you have to tell the which where the lymph nodes are involved. Like first you have to see the normal side, then go to your pathological side. Again, in the pathological side, no, you are going to do examination of axillary lymph nodes first.
Okay, sir.
So you have to mention that is specific.
Okay, sir.
So basically, how will you see the entry group of lymph nodes? How many stations are there in the axillary lymph nodes?
So, sir, uh, there are anterior group of axillary lymph nodes, posterior group of axillary lymph nodes,
So which
central,
muscle,
apical, and lateral.
basically, which muscle will divide the axillary lymph node station?
Pectoralis minor will divide the axillary lymph nodes in three groups. So, level one is below and lateral. Level
So
two is
level one is your
below and lateral.
okay.
Uh, Level 2 is between the pectoralis major and minor, and level 3 is above and medial to the pectoralis minor.
In
So
level 1, what all nodes will come?
Okay.
What all nodes will come under level 1?
Uh, in level 1, there will be
Anyone? What are the level 1 nodes? What are level 2 nodes?
level 2 nodes are Rotter's nodes, which are
Interpectoral nodes, rotor's nodes.
Rotter's nodes.
What are level 3?
your central and apical lymph nodes are there, no? Those will come under your level three. So your interpectoral
So
lymph nodes.
apical and central are over, rotors are over. Then what are your level 1?
So your anterior, your lateral group, and
Anterior,
your
lateral group.
anterior, posterior, and your lateral group. Okay. So your anterior, posterior, lateral is level one. Your rotor's lymph node is level two, and apical and central is your level three lymph nodes.
Yes, sir.
Okay. So subscapular area lymph nodes, I don't know. Like I have not seen this word subscapular lymph nodes. Basically, you have to see only your supraclavicular and infraclavicular area lymph nodes. Your
Okay, sir.
Subscapular
posterior,
is posterior group only,
posterior and
na?
subscapular both are same
Yes.
only. Not like separately you are going to see again a subscapular. So your
Okay.
posterior and subscapular is same only.
Okay, sir.
Okay. So how will you palpate the entry group of lymph nodes? Suppose this is your right side, no? Which hand will you use for palpation of entry group of lymph nodes?
Uh, I will ask the patient to put her right hand on my left shoulder, and I will use my right hand to palpate the
See, basic,
nodes.
you are palpating right side, no?
I will use my left hand to palpate the nodes.
So where will be the patient hand? Not on your left shoulder. Patient hand will be on your right shoulder. You will be standing
Sorry,
opposite
sir.
to the patient, no?
Yes, sir.
So ask the patient to make hand and ask the patient to keep shoulder on your your right side, your right hand. Ask
Yes.
the patient to keep hand on your right shoulder.
Right.
Then start palpating with your. How will you palpate it? Which hand you will palpate with your?
Left hand.
So see, basically your hand will be first. Ask the patient to keep hand on your right shoulder. Then with the how will be the position of your fingers while palpating the anterior group of lymph nodes? So
Mm,
basically, if you want to palpate the anterior group of lymph node, you are going and seeing the anterior axillary fold.
yes, sir.
So insinuate your finger in the anterior axillary fold. Okay. With the thumb, you have to press it back, and with the pulp of your three finger, you have to palpate the lymph nodes.
Yes, sir.
Basically, with the pulp of finger, you have to press it back,
So,
and again with
this is anterior axillary fold.
Yes,
This is
ma'am.
anterior axillary fold.
Yes, ma'am.
So, anteriorly your thumb is like this. Posteriorly your fingers are like this.
Yes, ma'am.
You will press with this thumb and you will palpate with this fingers.
Yes. Okay,
You
ma'am.
will press and you will palpate. You will
Okay,
press
ma'am.
and you palpate.
Okay,
so
ma'am.
that is your anterior. How will you palpate your lateral group of lymph node?
On the medial aspect of the arm, we will palpate with our
Against which
hand
bone?
against humans.
So you have to see, you have to tell specifically against upper end of humerus, you have to palpate the
Head
lateral
of the
group of
human
lymph node. So with which hand you will palpate your lateral group of lymph nodes?
with the right hand, sir. Now,
See, basically, if suppose if this is a patient axilla, so you have to ask the patient to abduct the axilla completely, okay? Then hold the hand of the patient like this and start palpating with your same right hand against upper end of humerus with pulp of your again your three fingers,
okay, sir.
okay? For lateral group, you have to use the same side, same hand,
Yes, sir.
okay? And posterior group of lymph nodes, what will be your position? You have to go to the back of the patient,
Back side of the patient, and
back
then
side of the patient. Again, see this is right side, no? Again, ask the patient to abduct his or her hand. Okay, you will be
yes,
standing behind, like how you have examined the anterior axillary fold, no? Same you have to examine the posterior axillary fold.
posterior. Yes, sir.
So for lateral and for posterior axillary fold, lymph node examination, you will be using same side, same hand.
Okay, sir.
Because in the examination, no, you will be having confusion of this for lateral and for posterior. Same side, if you are suppose using right side of examination, use your right hand only.
Okay, sir.
Rest your anterior, your apical, your central, you will be using your opposite hand. Suppose if you are seeing the right anterior group of lymph nodes, you will be using left hand. Suppose if you are using apical and central, you will be using your left hand.
Okay, sir.
Okay. So anterior is done, lateral is done, posterior done. How we are going to see the central group of lymph node?
Again with
Same.
the left hand,
Again, with the
pulp
left
of
hand, you will be standing in front of the patient. Ask the patient to keep her hand on your opposite shoulder or right
the
shoulder.
shoulder. Yes, sir.
Okay.
And
And then
palpate against what?
uh,
See, any lymph node palpation, you are telling against what? So in lateral, you are telling against humerus. Anterior
humans.
group, you are telling it against anterior axillary fold. Posterior group, you are telling about posterior axillary fold. Where do you palpate in central? Against the chest wall,
This
against
is
the
for
ribs.
the ribs. Yes, ma'am.
So which
How
ribs
do
you
you
will
palpate
palpate against
apical?
specifically?
Sorry, sir.
So which
Which
ribs
ribs do you
specifically you will
palpate?
palpate? The 12 ribs, no, not you are going to palpate entire 12 ribs.
Sorry, sir. No
So
idea.
you are going to feel the second, third, and only fourth ribs. You have to palpate second, third, and fourth ribs.
Okay, sir.
See, basically, this is the examination of lymph node station is very much important in the examination.
Yes, sir.
So basically, while seeing the central and apical group of lymph node, you have to ask the patient. You have to hold the patient hand like this. You have to ask the patient to do overhead abduction. So while palpating the lymph node, no, simultaneously you have to ask the patient to relax her hand like this. Simultaneously, you have to insinuate your finger. You have to palpate like this. Simultaneously, you will be relaxing her shoulder.
Okay, sir.
Okay. So same manner you will be doing for apical, and only the change is you will be applying the pressure to the shoulder from opposite side. See, you will be applying the pressure on your shoulder, pressure on the patient's shoulder like this. Simultaneously, you will be insulating so that you will be feeling the apex of axilla.
Okay, sir.
So you have to insulate your whole hand entirely in the apex of axilla. Like how you are feeling your ribs, lymph node in the central group, second and third core. No, for apical lymph nodes,
Mm.
press the shoulder. Ask the patient to do complete relaxation. Press the shoulder. Insulate your finger completely, entirely into the axilla. Go to the apex of axilla. Then feel the lymph nodes.
Okay, sir.
So those are your apical lymph nodes.
Yes, sir.
So how will you palpate your supraclavicular lymph nodes?
Sir, again with the on the
So
right side with the right hand.
no. You have to go
Sorry, sir.
behind the patient. You have
We
to
need
go
to
behind the
go
patient.
behind the patient. Yes, sir.
Okay, you have to
Behind
go
the patient.
behind the patient. See, basically, patient will be sitting. No, you have to come behind the patient. You have to
Yes, sir.
ask the patient to shrug her shoulder like this to make the
Okay, sir.
supraclavicular fossa more hollowness.
Okay.
Then put your finger like this in the supraclavicular area and feel any lymph nodes are involved here from back supraclavicular area.
Yes.
Okay. For
Yes, sir.
infraclavicular, again come from the front, insinuate your
Hmm.
finger and see if any infraclavicular lymph nodes are enlarged here.
Okay, sir.
Okay. So basically in some book they are given apical and infraclavicular lymph nodes are both the same.
Hmm.
In some book both they are given it is separate. In some book they have mentioned apical and infraclavicular lymph nodes both are same. So this is the examination of lymph node.
Okay, sir.
Okay, you will be forgetting many times, so always go and practice on the patient. You will be becoming more perfect on doing examination on the patient itself.
Hmm. Yes, sir.
Okay, can you go to your next slide?
So 1 minute, sir.
Okay, fine. So this is while doing see basically while doing provisional diagnosis, while telling the provisional diagnosis to the examiner, never utter the name of the patient. Just tell 54-year-old patient this and resident Sirur and Latur presenting with the, see you have to mention the chief complaint, any significant HUPI, any significant past history, personal history, family history. You have to mention all the things. On examination, you have to mention the positive findings on this. Okay.
Okay, sir.
After that, you have to
Okay.
tell the probable diagnosis, or after doing provisional diagnosis, you will be telling the it could be a case of carcinoma of the right sided breast with no evidence of any axillary lymph node adenopathy. Basically, you have to mention carcinoma of the right sided breast with no evidence of any axillary lymphadenopathy, with no evidence of any systemic metastasis on clinical examination. You have to mention like
Okay,
this.
sir.
So, this
Okay,
is a
sir.
case of right sided carcinoma of the breast without any axillary lymph nodes involved and without any clinical signs of metastasis by examination. So, examiner will ask you what is your TNF staging. So, how do you know breast TNF staging?
Yes, sir.
What is T1?
Uh, T1 is the tumor with the size less than 2 centimeter,
Okay,
and
next.
T2 is the size with tumor size with 2 to 5 centimeter.
Okay,
T3 is with the size more than 5 centimeter.
okay.
Then then T4A is with the involvement of the chest wall. Uh, then T4B is the involvement of the skin, and T4C
So this
is
T4A is involvement of chest wall. So the pectoralis major
chest.
and minor is not involved in the chest wall.
Yes, sir. Though no
But
pectoralis
your
major and
serratus anterior muscle is involved in your chest wall.
ribs and intercostal muscles will be involved in the chest wall.
Ribs, intercostal muscle, and your serratus anterior muscle.
Pectoralis anterior muscle, yes, sir.
Most of the time in
And
NEET, no, they'll be asking exam the point of this one, whether serratus anterior is covered in the chest wall or not.
uh,
And one more point is there. Uh, See,
okay, sir.
when you want to check the whether serratus anterior is involved or not, which quadrant you want to check?
Mm.
You are not see you have done the pectoralis major muscle, no? You have not done serratus anterior muscle involvement. So in which quadrant of the breast you want to do the serratus anterior involvement?
Uh, Outer quadrants, upper
So
and
predominantly outer and lower quadrant.
lower quadrant. Okay, sir.
So if your lump is in the outer and lower quadrant is lump is there, you have to see whether it is involved to the serratus anterior or not. So in that you have to do the serratus anterior muscle test. So how will you do the serratus anterior involvement?
Sorry, sir.
So basically see serratus anterior, no, you have to ask the patient to make her hand like this. You have to ask the patient to give some resistance. Basically, you have to ask the patient to make her hand like this, hold her hand, and ask the patient to do some resistance or put some resistance, or ask her to the push the any wall is there or anything is there. Ask her to push so that the lump will become more prominent.
Mm. Okay, sir.
Okay, ask her to push any wall or ask her to give resistance against you, so that in that first you move the lump freely, then ask her to do give some resistance and feel the lump whether lump is becoming more prominent or lump is becoming less prominent. So that is how you check for the outer lower quadrant any lump is there, then you will see the involvement of serratus anterior muscle. So now always don't do examination of serratus anterior, only when the lump is involved in the outer lower quadrant you have to do the serratus anterior involvement.
Okay, sir.
So what is your T4B?
So T4B is involvement of the skin, uh, which involves any ulceration or pseudo-orange
And your satellite nodule.
satellite nodules. Yes, sir.
Okay.
And
The next,
then
what is your T4C?
T4C. T4C will be both T4A and
A plus
T4B,
B. D.
and T4D is inflammatory cancer.
So D4D is your inflammatory breast carcinoma. So how will you what are
Yes.
the N staging?
Sorry, sir.
N nodal status.
N0 will be no regional node metastasis.
Okay.
Then
N1
N1 will be palpable, mobile ipsilateral axillary nodes are involved
palpable
in
mobile
N1.
axillary
Then
nodes. N2B.
mobile ipsilateral.
Okay. N2A.
N2A is fixed ipsilateral uh, axillary nodes.
Okay. Next. N2B.
N2B is the uh, presence of internal mammary lymph node and absence of axillary lymph node.
So presence of intramedullary lymph nodes without involvement of axillary lymph node is your N2B.
Axillary lymph.
Okay.
Yes, sir.
Uh, then what
And
is your
then
N3?
uh, so N3A is ipsilateral infraclavicular lymph node. Uh, N3B
N,
is internal mammary and along with axillary lymph nodes. And N3C is ipsilateral supraclavicular lymph nodes.
so N3C is your supraclavicular lymph nodes. So M0 is basically your metastasis.
Metastasis and no distal metastasis M0, M1 is distal metastasis.
Okay. So this is your case of T3 N0. Basically M0 you can tell, or MX is also fine, not specified and all.
CT3 and 0MX.
So a clinical
Yes.
TNM, no?
What
So you
does
have to
C
mention.
signify?
Yes.
So clinically, you are telling the staging, na? So it's CT3
Yes.
and 0MX.
Yes. Yes. Ma'am.
So based on your T3 N0 MX, so which breast carcinoma you will classify? There are criteria, there are categories are there. Early breast cancer is there, locally advanced breast cancer is there, or metastatic breast cancer is there.
So according to this, CT3N0MX, it will be early breast cancer. Uh,
Okay.
if there is involvement of any lymph node, and if it will become T3 N1 M0, then it will be locally advanced breast cancer.
See, basically, no, for
Or
locally, see, early breast cancer, no, T1, T2, or N0, M0, or you can take N1.
okay,
That is your early. Only T1, T2, N0, N1, and M0 that is the criteria.
But some people says T3 and 0 is also locally advanced. Some people
So
will
your
sorry,
T3,
early
your
breast cancer.
T3 is the no, T3 N0 MX is the no. So that is your borderline. So after doing your
okay,
investigation and all, if you find any lymph nodes in the investigation UAG, so it will go to your locally advanced breast cancer.
yes, sir.
So most of the time, no, billion it's even T1, T2, it comes under T1, T2 up to N1, that is your early. If there is a T3, if there is a N2, more than T3 or N2, N3, that is a local advanced breast cancer.
Yes, sir.
So what was the size of your lump?
Uh, the size was 10 by 8 centimeter. So it's more than 5 centimeter.
So 10 by 8 centimeter is there. So what you want to
T3.
be
On
mentioned?
you have any USG findings of this patient? In USG also they have given lymph node, no lymph nodes in axilla.
No, ma'am.
In USG, I think they have given lymph nodes in axilla, right? I have seen this patient. And clinically also there is a lymph node palpable, I think. This is I think I have seen this patient. Clinically also, there is one anterior axillary fold, one lymph node, and central also one lymph node is palpable. Acha 2 into 1 centimeter. But problem is now the patient is having very fatty axilla. So I think you are not able to appreciate it.
Okay, ma'am.
Yeah.
So
So based on this, if it is CT3N1, so where does this your it is going towards locally advanced breast cancer.
Yes, yes, ma'am.
So what all things you will do in locally advanced? How do you proceed?
Uh, First, we have to confirm with all the staging, and then we go for metastatics workups like CT, chest, and
Clinically, it's a breast cancer. What all things you have to do next? It is not confirmed yet, no.
so after confirmation,
How do you confirm
we have sent
your
the
triple
sample.
assessment?
See,
So
yes, ma'am.
whenever someone is asking the breast cases, how will you proceed? You have to tell, sir, I will go with the triple assessment. So to one part of
Okay.
triple assessment, your clinical examination is done. So what are the two parts? Next is
Next is imaging, and next is
so
uh,
next is your imaging. Next one is your tissue biopsy.
tissue biopsy or histopathological examination.
Okay.
What sort of tissue biopsy?
True cut biopsy.
To cut biopsy. What is the why to cut biopsy? Why not FNAC?
FNSC cannot differentiate between DCIS and uh, what we know.
Invasive cancer, invasive ductal carcinoma. What more?
So what is the size of your FNSC needle?
Sorry, sir.
Size,
Size of
size.
your FNAC needle. FNAC is 23 gauge. What is the size of the true cut needle?
18 gauge. 18 gauge needle.
14 is
18.
for your 14 gauge for your breast and 18 gauge is for your axilla.
Okay, sir. Okay, sir.
So along with your whether DCIS or invasive breast cancer, so what other points you will see in on doing throughput examination? Most important.
Sorry, sir. You are not audible.
On your true cut examination, what more things you will see? What are the things you will see in a true cut examination? You have done a true cut biopsy. What all the things you will see in the true cut specimen? You will see the type of breast cancer.
Yes.
You will see the grade. You
Mm,
will see whether there is any lymphovascular invasion.
yes, ma'am.
You you will get the histological type of cancer because some tumors are aggressive, some tumors are not aggressive.
Mm,
You will get the ER, PR, and head to new status.
mm, yes. Yes, ma'am.
So what four
So
things you will see? You will see the grade. You will see the lymphovascular invasion. You will
Invasion,
see
ERPR, and HER2.
ERPR,
And
HER2, and also the histological grade.
yes, ma'am.
Yeah.
so along with your ERPR, HER2, you have to do your Ki67 index, mitotic rate index. That is your Ki67 index. So there are four receptors you have to study. Estrogen receptor, progesterone receptor, HER2 and
Sir,
Ki67.
excuse me.
Uh, your voice is not audible. It's breaking.
His
It's middle.
voice is breaking, sir. It's not audible.
Okay.
Now it is audible.
No, it's not audible.
Hello.
So you have how do you take a true cut biopsy? How do you take a true cut biopsy?
Uh, Under local anesthesia, we will insert the needle uh, inside a tumor.
If you insert a needle, you have told the patient is having mark. Why does the patient will have mark?
Sorry, ma'am, we have to mark the tumor first, and then
It's 11 stab blade. You will have a stab blade now. You will make a stab. After that, you will insert the biopsy needle. You will make a short as a stab incision.
okay, okay, ma'am.
Yeah. After that, you will insert the biopsy needle. Yeah.
So
Okay, ma'am.
one more point, Nitin. Hello, am I audible now?
No, sir, your
No.
voice is breaking.
No. When do you do incisional biopsy?
Mm, Sorry, ma'am.
When do you do incisional biopsy? Incisional biopsy. This is two-cut biopsy. There are three different types of biopsies, right? One is two-cut, one is incisional, one is excisional. When do you do incisional biopsy?
Sorry, ma'am.
Whenever the two-cut biopsy is inconclusive,
Okay, ma'am.
you will do the incisional biopsy. You have to make sure now you what is incisional biopsy? Nothing. You will take an incision on the lump and you will take a chota sa piece of that jo bhi breast lump and you will send for again tissues whatever tissue histology something. So what one thing you have to make sure is you have to make sure the incision of this incisional biopsy can be included in the next incision. Whatever you stewart incision you will take no, for breast S-shape incision. It
Mm,
should be included so that
mm.
yeah.
Okay,
And while doing incisional biopsy, you have to make sure you should not use any diathermy. Matlab you should not use any cautery.
okay,
What happens if you use cautery? It will distort the normal breast because it is cancerous tissue, right? It will distort the cancer and everything.
okay,
And the second thing is you have to take only curvilinear incision while doing this incisional biopsy. You should not do a radial incision.
okay, ma'am.
Yeah, you have to do curvilinear incision. You should the incision which you are taking should be included in the next operative scar, whatever it is. And the third thing, you should not use diathermy.
Okay, ma'am.
So basically, you have done your true cut biopsy also. You have any report of true cut biopsy with you?
No, sir.
Okay, fine. So next we have done your true cut biopsy, everything. So basically, no. And what investigation you want to do? Radiological investigation.
Sorry, sir, I can't hear.
What radiological investigation you want to do in this patient? How do you proceed next? You have done a biopsy. How do you proceed next?
Uh,
It's a case of CT3N1. How do you proceed next?
uh, we will do CT chest for any
Actually,
metastasis.
before CT, no, you can do simple UAG, no.
Yes, sir.
So
Yes.
you want to
USG
know.
plus P you can do, X-ray lumbar spine you can do, X-ray PBH you can do.
Mm.
So
Okay.
basically, no, you want to do UAG breast with VAG axilla because you are telling you are not able to palpate the lymph nodes. So you have to do the UAG breast with UAG axilla. So simultaneously, you have to take the UAG guided biopsy, not some blind biopsy.
Okay.
Okay. So whatever there in the axilla, if any lymph nodes are enlarged, you have to take the UAG guided FNAC of the lymph nodes also. Because you have to see no whether lymph nodes are reactive lymph nodes or whether lymph nodes are due to metastasis. So because see
Mm.
if you have done the UAG and there are enlargement of lymph nodes and you have done FNAC and FNAC suggests of metastasis.
Mm.
So okay, so that is a local advanced breast cancer. So you have to subject the patient to chemotherapy initially. So if there are no evidence of any lymph nodes are enlarged, so you can go proceed with the surgery. So lymph nodes, seeing the lymph node status is very much important. Okay. So,
Mm.
so
Then
you
how
want
do you
to,
proceed?
basically you want to do any metastatic workup also. If suppose this patient is early breast cancer, so there is a no need of any doing metastatic workup unless and until patient is symptomatic or patient is having any elevated alkaline phosphatase level in
Mm.
early breast cancer.
Okay, sir.
But this is a locally
What does
advanced
the
breast.
raised alkaline phosphatase levels suggest? What does raised alkaline phosphatase level suggest?
Liver involvement or metastasis to liver.
Liver and what more organ produces alkaline phosphatase? Bone?
Sorry,
You
ma'am.
know any bone alkaline phosphatase? While bone resorption, alkaline phosphatase.
Sorry, ma'am.
So, see,
So for bone metastasis, you will see alkaline phosphatase.
Okay.
Okay. So so you have to do the CT chest, HRCT of the chest, and simultaneously you have to do the CT abdomen and CT pelvis. So triple study you have to do CT chest, CT abdomen, CT pelvis. So that is the indication for locally advanced breast cancer.
Yes, sir.
In which patient you will do PET scan?
Uh, if there are signs of metastasis
So
present
if there
in
is any,
patient like
so if there is
bone
any
pain or
local,
back pain,
yes, yes. So if there is any locally advanced breast cancer with signs of metastasis, or if it advanced breast cancer with metastatic, you have to do the PET scan before proceeding with the your CT scan.
PET scan.
Okay. So that is the
Okay,
CT,
sir.
that is the UAG. So if it is a young patient, you have to do the UAG. If it is old patient, basically you can do the what is the indication of mammography in this patient?
Uh, More than 40 years, we can go with the mammography. The
So in
patient
mammography,
age is more than 40
what
years.
are the findings suggested of malignancy in the
And
mammography?
in this specific patient, in this 54-year-old female patient, is there any use you do mammography?
Mm.
So opposite breast you have not ruled out yet, right?
Yes, ma'am.
So opposite breast ke liye you will do mammo. So
Yes,
what
yes.
are the features you will see in mammo?
Uh, Microcalcifications,
Okay.
med
What more?
metasets, uh,
What more?
satellite nodules.
Okay. Architectural distortion, satellite nodules, microcalcification. What more?
Uh, mm,
Thickening of the skin thicken, the skin will become thickened at the time at the place of malignancy. And
mm,
if at all nipple retraction, anything is that you can nicely see the nipple retraction. And which
mm,
type of calcification? It is mostly around lymph nodes. True. Architectural distortion of lymph nodes, or you will also see. True.
mm,
You will also see stippled. It is mostly stippled microcalcification, which is specific to malignancy.
mm. Okay, ma'am.
Yeah. And you can also see the multicentricity, right? In the same
Uh,
breast. In the mammo, you can also see if at all there are chota lesions which you are not able to palpate, multicentricity.
uh, yes, ma'am.
Yeah, yeah.
So what is multicentricity, multifocality?
Uh, Multicentricity means the tumor foci are present in all quadrants of the breast, and multifocal means the multiple foci are present in single quadrant of the breast.
Okay.
Socho, I am having a breast like this. Socho, I am having a breast like this. So this is the four quadrants. These are the four quadrants. I am having a lump here and I am having a lump just 2 centimeters away in the other quadrant. Can it call be multicentric?
No, ma'am. There should be distance more than 5 centimeter between two,
Yeah. So it should be in two other quadrants, and the distance between the two lumps should be greater than 5 centimeters. If
rather
it's
than
less
five
than
centimeters.
5 centimeters, you call it multifocal only.
Yes, ma'am.
Yeah.
So what is your viral stage? Viral stage is there, no?
Um, yes, sir.
You have any idea of virals?
Uh, yes, sir. BIRADS means breast imaging reporting and data system,
Okay.
uh,
So based on UAG and
which is
mammography, you are
divided
indicated to okay. Divided into how many?
uh, 7 scores. So
Oh,
0 to 6, total 7.
So what is viral
yes.
0, viral 1?
BIRAD 0 means there is need of additional imaging required and likelihood no chances of cancer.
So there
BIRAD
is
1
viral 0
means
is basically is incomplete assessment.
yes.
Inappropriate assessment.
Okay, okay.
So your virals
Then
1 is
BIRADS 1 is negative. Uh, in BIRADS 1 we will require routine screening in 1 year. and then Byrat's 2 is benign category, uh, in which here also we require routine screening in 1 year. And then Byrat's 3 is probably benign, uh, in which we need a short-term follow-up within 6 months. And then Byrat's 4 is suspicious category, in which we, we, we need to do tissue biopsy. Then Byrat's 5 is highly
So in
suspicious of malignancy.
Byrat's 4, no, there is a 4A, 4B, 4C. So 4A is
Uh,
low, 4B is intermediate, and 4C is your high suspicious of malignancy.
yes, yes.
So ठीक है, so
So
4A is your 2 to 10%, 4B yours are 10
yes,
to 50%, and
10 to
4C is your
50,
50 to 95%.
50
50
to
to 95%.
So in
95.
this all the patient biopsy is the must.
Yes, sir.
So your 5 is your highly suggested of malignancy. In that there is a risk of more than 95%. So in this patient you
Yes,
have to do biopsy or you have to do surgery. Birad 6
yes.
is biopsy proven malignancy. You have to operate the patient.
Fine. Yes, sir.
Okay, so that is the Birad, your Birad staging is there. And and you have done everything in this patient. And what you want to do now in this patient?
You,
Mm. Sorry, sir.
what do
Your
you want to do? What do you want to do next? It's a T3, N1, M0. The metastatic workup is negative. What do you want to do in this next in this patient?
uh, next, we will suggest neoadjuvant chemotherapy
Okay.
See, one
before.
thing, no, Nitin, you have done UAG and UAG XLI suggests you have lymphadenopathy.
Sorry, sir, you are
Uh,
not audible.
your voice is not audible. He's asking is, imagine your USG is suggestive of lymphadenopathy. That's what
Mm,
you're asking, Ismail.
Yeah, yeah. And you have done FNAC also, and FNAC suggests you of your metastasis into the lymph nodes.
mm,
Okay. So
yes.
you want to do sentinel lymph node biopsy in this patient.
No, sir. If there is already uh, evidence of metastasis, then we will not do a sentinel lymph node biopsy.
So sentinel
So
lymph node
when do
biopsy.
you do sentinel lymph node biopsy?
Only early stage cancer we have to do sentinel lymph
So
node
it's
biopsy.
you will do negative sentinel lymph node biopsy in a negative axilla.
Yes.
When so okay, and in what more condition you will not do sentinel lymph node biopsy?
So what are the
What are the
contraindications?
contraindications of sentinel lymph? What are the contraindications of sentinel lymph node biopsy?
Uh,
In multifocal disease also you can't do sentinel lymph node biopsy.
yes, ma'am. And if there any previous
Operative
surgery,
scar you can't do,
operative
yes,
scar is there,
because the
then
lymphatics will be distorted,
lymphatics will
and
be disoriented, and that.
positive axilla,
Yes, ma'am. Positive
previous
axilla.
radiotherapy.
Yes, ma'am. Previous
Yes,
radiotherapy.
yes. What when can be there a false negative sentinel lymph node biopsy? When can be there false negative sentinel lymph node biopsy?
Uh,
So, see, even though if it's a small tumor, na, but it is having abnormal architectural distortion, बहुत
mm,
ज़्यादा fibrosity, this dye will not pass through the sentinel lymph node. You know what is the concept of sentinel lymph node?
yes, ma'am. It
What is
is.
sentinel lymph node?
It is the first lymph node that is invaded by the tumor cells.
Which is nothing but if at all we give a dye, what is the first lymph node? The dye become positive.
Positive, yes, ma'am.
Same. So how do you do the sentinel lymph node biopsy? What are the different techniques of sentinel lymph node biopsy?
So there is a dye method in which we
Okay,
use methylene blue or isosulfan blue
okay,
injected in uh, periareolar subdermal periareolar plexus, and then we will look for the staining. And there is
yes,
also one method of radioactive level method in which we use technetium 99
yes.
sulfur colloid,
And with
in
gamma probe, you will see.
gamma probe will be visualize the lymph nodes, and
Can these both techniques use it together?
Yes, ma'am. Both techniques is the best
If
method
if
for. Uh,
if we use both the techniques, the sensitivity is very much high. It all goes to 90%.
yes, ma'am. Yes.
Yeah. How many in the sentinel lymph node works? So you have injected dye. It's an early breast cancer. So peritumorally you have injected dye.
Yes, ma'am.
So in gamma camera, how do you tell this lymph node is positive? You know anything? You know.
Mm,
So you will see the radioactivity. You are only telling now you I am injecting technetium 99 radioactive material.
yes, ma'am.
So on gamma camera, you will see any lymph node which is taking 10, which is giving 10% of the radiation.
Okay, ma'am.
So imagine you are giving 100 radioactivity to the patient.
Mm,
So if any lymph node has a radioactivity of 10, you will pick that lymph node and you will label it as a sentinel lymph node.
okay, ma'am.
And you will remove the lymph node. Like that, how many sentinel lymph nodes you will remove?
So, minimum 10 lymph nodes.
Minimum 10 lymph nodes you will remove. For only, I'm asking only
That
sentinel lymph node
is-
biopsy. You are giving sentinel dye. You are getting 4 or 5 lymph nodes positive. Then you can remove 10. You can pick almost 10 lymph nodes and you can come out. Imagine there is only one lymph node positive. Still, you will pick 10 nodes.
Mm, sorry, ma'am.
You will do only 2 to 3 nodes and you will come out. Because it is
Okay.
only one node positive. Now, why to distract all these axilla? If you distract axilla again, you know, na Steve-Tripp syndrome will come, lymphedema happens.
Mhm.
So if only one node positive, you will pick 2 to 3 nodes and come out. If there are more number of lymph node positive, you will do axillary dissection.
Mm, okay, ma'am.
Yeah,
So
that's
that
what I
is
want to
the
tell. I want to tell that if one node positive now, if one node positive, you will not go to aggressively axillary dissection. You will pick 2 to 3 nodes and you will come out. You will play safe game. But if multiple lymph nodes are positive and in sentinel node biopsy, then you will do axillary dissection.
Okay, ma'am.
Yeah.
so your three or more lymph nodes are positive, then you will go ahead with the axillary lymph node dissection.
Okay.
Because axillary lymph node dissection is associated to morbidity also, because patient will be having any nerve injuries, patient will be having difficulty in the shoulder movements, patient will be having numbness, patient will be having lymphedema chances. So there is axillary lymph node dissection is it is kind of morbid procedure.
Mm, yes, sir.
Okay. So in this patient, you have done metastatic workup, lymph node is also positive, and this is a local advanced breast cancer. So how do you proceed now?
Now we can suggest patient neoadjuvant chemotherapy to reduce the tumor size before any surgical intervention.
So before starting with the neoadjuvant chemotherapy, you know what you want to do? So you have to do you have to do basic complete blood count. You have to do basic renal function test, liver
Okay.
function test, because all your
Yes.
chemotherapeutic agents, no, these are the cytotoxic agents, because
Yes,
it
ma'am.
leads to bone marrow suppression, anemia, and specifically you have to see the old age patient is there, no, middle age old age patient. You have to see the
Mm,
cardiac status also, because your anthracycline is there, no, doxorubicin, daunorubicin, those are the cardiotoxicity, and
Cardiotoxicity.
also your hertuzumab. A
mm,
trastuzumab drug is there, no, HER2 receptor antagonist trastuzumab. That drug is also your cardiotoxic. So you want to see the
So
patient
you
cardiac profile also.
and while giving chemotherapy, na, the chemotherapy in breast cancer is designed in a beautiful way. Never trastuzumab and this doxorubicin are given at the same time
So you
because
should not
both are
ever
cardiotoxic. It will give extreme cardiotoxicity, right?
okay, ma'am.
Yeah.
Mm,
So okay, you are telling we'll start chemotherapy. So the patient is having ER/PR positive and HER2 negative. You can't give trastuzumab for this patient, right?
no, ma'am.
So what is the most common regimen which we'll give in a CA breast?
Uh, for HER2 new negative, 4 cycle AC or EC, and then 4 cycles of taxanes.
What are the drugs? Roughly tell. It is an anthracycle based regimen or taxane based regimen. What are the
Adriamycin,
drugs we'll give?
4 cycles of adriamycin, cyclophosphamide, uh,
and four
epirubicin,
cycles of your four cycles of your taxane.
Taxane.
and then 4 cycles of taxanes.
Okay. What is the
So
most
what are
common
the
complication of taxane?
Sorry,
You
ma'am.
have taxanes are paclitaxel and docetaxel, right? What are the most common complication of taxane?
Sorry, ma'am.
It's peripheral neuropathy. Patient will have very bad peripheral neuropathy.
Okay.
Yeah. So your anthracycline and your what do you call anthracycline is doxorubicin. You will have and your trastuzumab has cardiotoxicity and your taxanes has peripheral neuropathy. Okay.
So what are the indication of your neoadjuvant chemotherapy, Nitin?
Uh,
One is your local advanced breast cancer. What are the indication
uh,
in early breast carcinomas? In which patient of early breast carcinoma you will give the neoadjuvant chemotherapy?
Next question.
if it's ERPR negative,
That is your triple negative.
Triple negative.
negative, uh, positive lymph nodes,
Any lymph node in the axillary positive, you have to give the chemotherapy.
and metastasis, if there is any metastasis.
No, 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 no.
Early breast carcinoma, there is no problem of metastasis, no? That's why we are calling it
Sorry.
as early breast carcinoma. So if it is a triple negative breast cancer, if it is HER2 positive breast cancer, also you have to start the chemotherapy for HER2 positive also. If
Okay.
you are planning the patient breast conservative surgery and your lump is bigger in the size, you have to reduce the size, then you have to start the chemotherapy to the patient.
One more thing, lump is to breast ratio you will see.
Uh, Okay,
So the
ma'am.
patient is having only small breast. If it you will thin females, you will see that the patient doesn't have a good breast tissue. Even though 3 centimeters lump for a small breast is a big lump, right?
Yes. Yes,
So
ma'am.
still you want to decrease the size in order to conserve her breast. Still you will go for chemotherapy.
Yes, ma'am.
Yeah.
And one more is also in the premenopausal woman. If the woman is less than 50 years, basically you have to start with the chemotherapy because as much as you want to preserve the breast tissue. So there is an indication for neoadjuvant chemotherapy. One is your local advanced breast cancer, as in our patient, and other patient if HER2 positive, triple negative breast cancer. If you are planning for BCS, any premenopausal woman, or if there is any axillary node metastasis. So in this all patient, you have to start the neoadjuvant chemotherapy. Any indication for neoadjuvant hormonal therapy?
Mm.
Suppose if this is the case of old age patient, 80 years, 60, 70 years, patient is unfit for surgery, she is having multiple comorbidities, she is having metastatic disease. In that patient, you have to at least start the hormonal therapy to the patient because you can't give to the chemotherapy and you can't do extensive surgery, you can't do radiotherapy. If there's old, if the patient is very much debility is there, immunocompromise is there, you have to do the trooper biopsy, take the ERPR receptor status, and you have to start the estrogen and based on receptors. Based on postmenopausal, you will start the aromatase inhibitors.
Mhm.
Okay?
Premenopausal woman, what you will start?
In premenopausal, we will give SCRM.
Array, we are asking about neoadjuvant. Na? Premenopausal given you will not give anything.
Sorry, ma'am.
After
Sorry.
doing MRM, na, we'll give.
Yes, yes. Sorry, ma'am.
Yeah,
Sorry.
we'll not give. It's an adjuvant therapy. Whatever you are telling is adjuvant. We'll not give neoadjuvant chemotherapy, hormonal therapy in premenopausal women. One more
So,
thing I want to ask: in sentinel lymph node biopsy, now what are the different tumors you will do sentinel lymph node biopsy?
apart from breast,
I think I have missed that question.
Apart from breast, penile cancer
And one more,
and uh,
malignant
melanoma.
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 Yes, yes, yes. Good.
so sentinel lymph node biopsy will basically will do in the breast cancer, penile cancer, and malignant melanoma.
Melanoma.
Okay. So you are going to start with the neoadjuvant chemotherapy in this patient. So before doing the neoadjuvant chemotherapy, suppose this patient she want to do breast conservative surgery in the future.
Mhm.
She's telling you, I don't want to undergo mastectomy. I just want my breast to conserve. So what will you do now before starting chemotherapy?
One more thing. If it's an young female, na, before making this surgery, before giving adjuvant chemotherapy and all those, always explain about her fertility status. You tell you can. There are many other things of fertility preservation these days, like egg preservation, embryo preservation. Always explain about her fertility then, because the chemotherapy drugs are toxic drugs.
Mhm.
Yeah.
Yes, ma'am.
So she wants to consider her breast. So what you want to do before starting the chemotherapy?
Yeah.
So before going to the chemotherapy, basically you have to label the tumor. You have to mark the tumor specifically if any magnetic seeds, or if there is magnetic seed is not available, any radioactive substance. If radioactive substance is not available, you can use at least your PVC catheter, polyvinyl chloride catheter is there, no? Or any suture material. You can mark the size of lump, because after starting chemotherapy, the lump will diminish like anything. It will reduce in the size like anything if it is response to chemotherapy. Okay.
So
So
what do
basically,
you do is you will, with the help of USG guided thing, you will keep a small marker in that where the tumor is there.
Okay.
So imagine the patient is responding very nicely to your neoadjuvant chemotherapy, and suddenly the lump disappears, responding to chemotherapy. Where do you operate? You have to have a marker, na. This is the
Hmm.
point where the previous lump is. Here I have to operate. So for that you will keep a marker.
Okay.
okay, so basically you have to keep the marker in this patient. So you have started the chemotherapy. So how many
Hmm.
cycles after the starting chemotherapy you will assess the response to chemotherapy?
Hmm.
So basically you have to start the chemotherapy and you have to see after 2 cycles of chemotherapy whether the tumor is responding or not. So how will you see whether the tumor is responding or not?
Hmm. We will that we will see the reduction in size of the tumor,
So
and
what it is called as?
there are new
What?
lesions.
No, no. Indirectly, we are asking: is there any criteria, named criteria, to see about the
Yes,
response
ma'am.
of
Yes, ma'am.
chemotherapy?
There is a racist criteria
Good, good,
for
good.
this. Uh,
What is the full form of
What is
RECIST?
RECIST criteria?
so it CR means complete response, in which
No, no,
uh,
no. What is there is a RECIST criteria, right? What is the full form abbreviation of RECIST criteria?
response evaluation criteria in solid tumors.
So this is not only used in breast. This can be used in any solid tumor which we
Yes,
are giving neoadjuvant chemotherapy.
So
yes, ma'am.
basically, you have to give the
Now,
2 cycles of chemotherapy. After giving 2 cycles of chemotherapy, evaluate the tumor how it is responding. So basically, you have to see the size of the tumor. So if the tumor is clinically and imaging wise clinically it is showing complete disappearance, that is your complete response. So what is suggested
Yes,
of progressive response? So if there is any 30% reduction in the maximal diameter of the tumor cells or tumor tissue, if there is any tumor lump is there, if there is 30% reduction in the size is there, that is your suggestive of your progressive response. And if it is a stable disease means if you are giving chemotherapy but the size of the tumor is decreased only 30%, that is your stable disease.
Ismail,
And
your voice is
sir,
breaking.
your
Your
voice.
voice is breaking. Okay, it is you have different terms. You have complete response, you have partial response, you have stable disease, and you have
progressive
progressive
disease.
disease.
Comprehensive disease. Yes,
So, what is complete response? The tumor has disappeared completely.
yes, yes, ma'am.
What is partial response? Greater than 30% reduction is there.
But there is a
Yes, ma'am.
partial
So,
response.
if the tumor is 10 centimeters, the tumor is 10 centimeter. Almost now the present size is 3 centimeter. There is 3 centimeter decrease in size.
Hmm.
The present tumor is 7 centimeter. So that is
Seven.
partial response.
Okay.
What is stable disease?
There
The
will
So there
rejection
be
is
is less
no.
than 30%.
Okay. Okay,
Yeah.
ma'am.
What is progressive disease?
More
There
than
is no reduction. Yeah. In spite of being reduction,
Hmm.
there is growth in tumor, or there will be any some more lesion, one more lesion coming other than the main tumor.
So there is a
Yes,
more than 20% increase in the size of the tumor. So that is your progressive disease.
yes,
So if there
yes.
is any if there is any complete response, if there is any partial response is there, that is a good response is there. So you have to continue the same cycle of chemotherapy.
No, your voice is breaking. What he's telling is, if at all the patient is having complete response and the patient is partial response, so you can continue with chemotherapy. Matlab, somehow the patient is responding, but the
Hmm.
patient is having stable disease or progressive disease. then what you have to do? I think that is the question.
Yes, 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 yes. Nitin,
Then what you will do?
Then then we
you are
continue
starting.
with the uh,
You are
chemotherapy.
starting the chemo. You have started the chemotherapy, but chemotherapy is not working. So basically,
Sorry,
no,
sorry.
you. So basically, you have
You
to
will
consider.
complete the chemotherapy. You will complete the chemotherapy, or you change the regimen. What we want to ask is whether you will complete that chemotherapy or you will go. This patient is not responding, so I want to change the regimen. What you will do?
Should we complete the
We will
chemotherapy?
come.
Yes, we will complete the
See, basically,
chemotherapy.
no, basically, no, chemo is not responding, no. So you have to counsel the patient that you have to do mastectomy.
Hmm.
Hello. So basically, if the chemotherapy is not work, if the response is not showing after 2 cycles of chemotherapy, you have to counsel the patient that this chemotherapy is not responding. So there is a chances of terminating the breast conservative surgery. We can go ahead with the mastectomy. There is a one more mastectomy, and another one is you can add the second line of chemotherapy. You have told no paclitaxel, carboplatin. These are all the first line chemotherapy. So there are capecitabine, there are gemcitabine, there are multiple second line chemotherapeutic agents are there, but these are the more cytotoxic chemotherapeutic agents. And also there are molecular drugs are available, such as CDK4/6 inhibitor. Those are the palbociclib and all. So you can add the CDK4/6
Palbociclib.
inhibitor. So that is your palbociclib. So you can add the second line of chemotherapy, or you can add the molecular therapy such as palbociclib and all, or you can tell the patient that we want to continue with the mastectomy instead of breast conservative surgery.
Okay.
Okay. So basically, if the chemotherapy is working, continue the chemotherapy. If the chemotherapy is not working, either switch over to the second line or switch over to your surgery.
Okay. Yes.
So what kind you have given neoadjuvant chemotherapy. The patient is having a good response, complete response. Uh, so in this patient, we are not talking about early breast cancer. In this patient, you have given chemotherapy. The patient is having tumor of 10 centimeter, it has shrunken to 3 centimeter now. So how do you do surgery? What is the incision you will do? What is the position you will give?
So in breast conservative therapy,
No, I'm not talking about breast conservative surgery. I'm talking about this patient. It's T3N0 disease. Initially, after giving neoadjuvant chemotherapy, the it is 3 centimeter in this patient. We are not talking about breast conservative. You are talking about MRM. What will you do?
uh, in MRM we will give elliptical or stewart incision uh,
Okay.
over the breast, and then we will remove the breast nipple
Any
area.
specific position? Arm abducted, arm adducted, anything
Will be abducted. What's it?
abducted?
So supine
Sorry.
position, no?
Arm will be abducted while keeping the position or adducted. Supine position. You will keep one towel underneath the breast so that the breast tissue gets little elevated, little prominent.
Hmm.
Arm not completely abducted, not completely adducted, slight abduction, slight abduction, not complete abduction.
Okay, ma'am.
Okay.
So what
Then
are the boundary? What are the boundaries of your MRM
what are the
mastectomy?
your voice is not audible. What are the boundaries of MRM? Your voice is not audible. Nitin, what are the boundaries of MRM? Where do you raise the flaps?
Uh, Upper flap is up to the uh, clavicle, and then lower flap is
Lower flap is array. You have to tell fast, fast. This is theory only.
uh,
Intramammary fold. Then medial flap.
medial is to the lateral border of the sternum. Medial is
Yes.
to the lateral
Lateral
border of
flap.
sternum, and it's up to the mid-axillary line. Mid-axillary line.
Okay. Okay then.
See,
How much
basically,
thickness of that skin tissue you will take? You are raising the flaps, no?
So,
Continue, Smith.
Sorry, ma'am.
Basically, initially they used to tell up to we have to lift up to infraclavicular area, but now in recent bill, they are telling you have to lift the upper crab up to your second rib, and well, medial side you have to go towards the lateral border of sternum, and inferiorly you have to go till only the inframammary fold, and your
Okay,
lateral
so
boundary is
So
your
superiorly before it's clavicle, na? So what he's telling? Superiorly it's clavicle before. Now it's second rib.
okay, okay, ma'am.
Yeah.
and lateral boundary is your anterior border of your latissimus dorsi.
Hmm. Okay, sir.
Okay. So what will you do next?
Then
So so you have done the
then we
mastectomy.
will do the.
How much thickness is the flap? You have not told me.
Sorry, ma'am.
It is roughly 8 mm. 8 mm thickness flap you will raise.
Okay, ma'am.
Yeah. What are the different modifications of MRM?
When it's related to the pectoralis minor muscle.
Yes.
When it's retracted, it is called as occiput, and
Okay.
when pectoralis minor is cut and rotus lymph nodes are removed, it's patties, and there is another one known as scanlon.
You will divide.
Uh,
You will divide at its insertion.
yes, yes.
What is the insertion of pectoralis minor?
Coracoid. Yes,
Great, great. Coracoid process, yes.
yes, yes.
What are
So
the structures you will preserve in MRM?
so which one will do? We will
Uh,
do which MRM,
Long
which type of
thoracic nerve.
MRM we will do?
Regularly, what kind of MRM you will do?
Spatis, I think.
We'll do the osteoclasis.
No,
We'll only the retract it. We will not cut it.
we'll only retract and we'll remove only level 1 and level 2. We'll not remove level 3 normally until unless it is enlarged.
Okay, ma'am.
Yeah.
Okay.
What are the structures you will preserve in MRM?
Long thoracic nerve,
Okay,
and then thoracodorsal pedicle.
okay. Axillary vessels, cephalic vein,
Yes, ma'am.
thoracodorsal nerve, nerve to latissimus dorsi, and pectoralis major.
Okay.
So what are the boundaries of your axillary dissection?
Superiorly, it's axillary vein. Uh, Laterally, it's thoracodorsal pedicle, which is lateral boundary. Inferiorly, it's angular vein, and medially, it's Halsted ligament.
Okay. Uh, so basically, you have done the surgery. You have done everything nicely. So which one is the most common nerve injured while doing MRM or while doing axillary dissection?
Uh, Most common injury,
Yes,
Most
most
common
common
nerve
nerve
injured.
injury.
intercostobrachial nerve
Good,
is
good.
most commonly injured.
How will it manifest?
It will cause numbness and reduce sensation in axilla.
So upper medial aspect of arm.
Uh,
So specifically upper and medial aspect of arm. If there is involvement of long thoracic nerve injury, how will it manifest?
it will cause winging of scapula.
So if there is injury to the thoracodorsal pedicle, what will happen?
Uh, it affects mainly the latissimus dorsi and
So what is the importance of latissimus dorsi? So basically latissimus dorsi,
What,
you can use
what is the action of latissimus dorsi? He's asking what is action of latissimus dorsi.
uh, sorry.
So basically, if this latissimus dorsi muscle is there, no, you will use it for future flap. So that is why it is
Uh,
very much important to preserve it. Okay, basically it
And
is used.
overhead abduction also latissimus dorsi helps, na?
Uh,
Yes.
yes, ma'am. Yes, ma'am.
What happens if serratus anterior gets involved?
So, sorry, ma'am.
Serratus anterior, winging.
There will be winging of scapula.
Yeah, yeah.
Uh,
So basically, you have started with the neoadjuvant chemotherapy, and you have done the mastectomy. You have done everything. And what you want? You want to give any radiotherapy? What are the indications for radiotherapy?
uh, Sir, if uh, indications for radiotherapy are breast conservation therapy,
Yes,
breast
yes,
conservation
good.
surgery, and
Yes,
then after total mastectomy, eradication of axilla. Uh,
yes, means local advanced breast
uh,
cancer.
yes, ma'am. If patient comes with high risk of relapse, then we have to give radiotherapy.
Yes, yes.
Uh,
Margin positivity, relapse. What more?
yes, and if there is subtypes like triple negative or HER2 new enriched, uh,
Okay.
then we have to, then
If there is
inflammatory,
positive, yes, if there is positive axilla, you will give.
uh, then
So you have done the axillary. You have done
inflammatory
the.
C.
Okay, fine. You have done the axillary lymph node dissection. You want to irradiate the axilla now?
Mm,
So you are very well sure you have done a good axillary lymph node dissection. Still, will you eradicate? Still, you give radiation. Will you give radiation to axilla? That's what he's asking.
mm. Yes, sir.
No, no, you should not. You never give to the irradiation of axilla. If you have done axillary lymph node dissection, you have to just irradiate your the memory area.
Mm,
Breastbed,
Breastplate
okay,
you
sir.
have to irradiate, not
mastectomy.
your axillary lymph node dissection.
Kyuki now, if you are giving radiation again, na, the chances of a Steve syndrome, your
Mm,
lymphedema
Lymphedema.
increases, na? Lymphedema.
mm. Okay.
I
So
think
you have done
so.
everything, and you have the specimen in your hand. And what specifically pathologist you want to see in the specimen?
One more thing, how do you mark the specimen? How do you mark the specimen? This is important, they'll ask.
Mm, sorry, ma'am.
How do you mark the specimen? So it's long lateral. So on the lateral border of the mass, that if this is the mass, this is the lateral border. You will keep a thread, long thread. You will hang a long thread, and you will keep a short superior thread. So while the specimen is going to pathologist, she will know wherever there is lateral long thread, it is the lateral margin of the lump. Where there is a short thread, it is a superior margin.
So
Okay.
you have to keep the thread long lateral
LL,
and short
long lateral,
superior.
short superior.
Mm, okay.
So what specifically you want to ask the pathologist? Which are the factors you want to ask the pathologist to see in this?
Sorry, sir.
So basically, you have
I
to ask the
think we have
you have
busted his brain.
okay fine. With 5 minutes, basically you have to ask the pathologist first which kind of tumor it is. What are the different pathological types of the tumor? You have to ask the patient. You have to ask the pathologist whether it is lymphovascular invasion is there. You have to ask the pathologist how many lymph nodes are
Same, the
involved.
true cut biopsy. What all things you have seen? Same, what all things you have seen in true cut biopsy? Same things you will ask, na?
Mm,
So you
okay,
have to
ma'am.
ask the patient margin status also, pathologist. You have to ask the pathologist about your lymph node status. So there is a based on that, no, there is a Nottingham criteria is there. So read about Nottingham
Mm,
criteria.
How many?
If there is
If you have sent 10 lymph nodes, in 10 lymph nodes, how many lymph nodes are positive?
mm,
So there is a
so based on your Nottingham
okay.
criteria is there, no? Based on Nottingham criteria, if the criteria suggests you of a poor or a criteria suggests you of moderate, no, again you have to subject the patient for adjuvant chemotherapy or any adjuvant radiotherapy. Adjuvant treatment you have to give to the patient, and you have to see the ERPR receptor also, so that you have to the keep to the patient on your hormonal receptor status also. You have to keep the patient on a hormonal therapy also.
Mm,
So basically, this is all the management of your
okay.
locally advanced breast cancer.
oh, last question. I want to ask you one more question. So Dr. Ismail have clearly mentioned if at all the patient has you have done axillary dissection, you will not give any radiotherapy, right?
Yes, ma'am.
So when do you give radiotherapy, even though you have done axillary dissection? Is there anything which you can think, अरे patient में axillary dissection किया था, फिर भी patient को let us give radiotherapy? You are scared, any conditions? So if at all, while doing axillary dissection, you are not able to pick minimum 10 nodes. You have to pick minimum 10 nodes, right? I have told you
Yes, ma'am.
10 nodes you have to pick. So you are not able to pick 10 nodes. You are doing only 6 to 7 nodes. Then you have to give
Radio.
radiotherapy because your axillary dissection is not complete, right?
Hmm. Yes,
If
ma'am.
at all, if at all there is a big lymph node and there is an extranodal spread,
Hmm.
matlab outside the node also there is tumor coming. Node is fully involved. There is an extranodal spread. Then you have to give radiotherapy. The third thing is if at all there is a very great lymphovascular invasion, very huge lymphovascular invasion is there, then you have to give radiotherapy. Even though you have done axillary dissection, these are the three indications where you have to give radiotherapy.
And
Okay, ma'am.
how will you ask the patient to keep follow up with you?
Hmm.
So first 2 years, no, you have to call the patient every 3 months. Okay, first 2 years. Again,
Yes, ma'am.
next 3 years, you have to ask the
Hmm.
patient to come for every 6 months. After that, you have to ask the patient to
Hmm.
come yearly, and you are doing yearly clinical examination, and you are doing mammograph also yearly. If you have inserted any implant, if you are suspecting any scar recurrence, if you are thinking in terms of recurrence, you have to do depends on that. You have to do
Hmm.
MRI breast and all. So basically, initially
Hmm.
3 monthly for 2 years. Next is for 6 monthly for 3 years. Then you have to ask the patient yearly with mammogram and
Hmm.
clinical examination. If you have put any implant, you have to do MRI breast.
Okay, sir.
Okay. Dr. Bhargavi, do you
Okay,
want
sir.
to ask anything?
No, 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 no. Let's end this.
See, this is a basically locally advanced breast cancer is there, locally advanced breast carcinoma. So this is how we'll manage the locally advanced breast cancer. So in book is also given nicely. Go and read
Yes.
properly like how chemotherapy is management, how surgery is managed. Because whenever you are seeing the patient, no, don't go and just operate it. First, due to the chemotherapy, downgrade
Hmm.
the tumor, then operate it. Because when
Hmm.
you are operating directly, no, patient will be having 10 days in the work to wound to heal. Patient will be having some kind of infection, some kind of seroma. It will delay the chemotherapy. And again, patient will be having metastatic. Initially, patient will be having metastatic rapidly. So CA breast is no, it is very metastatic disease. I have seen we have operated one patient for a local advanced breast cancer. We have operated first, then patient had some surgical site infection, patient had seroma. So she had some complications. So chemotherapy was delayed for almost 1 or 2 months. So again we have started chemotherapy, and
Hmm.
in the
Sir,
receptor status it was HER2 new positive, and it was my one of my friend's mother only. So within 6 months she had developed massive pulmonary metastasis, and after 8 months patient succumbed.
So,
So this is not only just we are like simply we are
and I
spreading
have
here
a
and all.
patient. It is a locally advanced breast cancer. Matlab
hmm.
before I was joined. The patient was already operated 6 months before. The patient was from some other village. The patient didn't take chemotherapy because she thought of it, I got operated. So counseling is very much important in any malignancy. If you are not able to counsel the patient, now I'll tell don't operate because
Hmm.
it is not going to make much difference. Na? So 6 months the patient came with spinal metastasis. Itna very bad spinal metastasis. The patient is having continuous lumbar fractures.
Hmm.
There is a you will have the body, na the body got
Hmm.
fractured. I think we have admitted the patient and I have discharged it. The next time into I think third month she have came to my trauma only in gasping and she have died. So it is very much important
Okay, ma'am.
how you manage all those. Nitin, very great presentation actually. Very great presentation. Just now
Thank
I
you.
think you would have got an outline of everything, how
Yes.
everything is done. Just
Yes.
go and just read one more time. I think you are good to go to present even in final.
Yes, ma'am. Thank you, ma'am.
Yeah.
Yeah, really good presentation.
Thank you so much.
Okay, okay. Thank you everyone for
Thank you, sir.
joining. Okay, thank you. Chalo, bye bye.
Yes.